Good evening, everybody, and welcome to tonight's Twilight Online 5 Steps to Delivering the Best Care for Your Aboriginal Patients webinar. I'm your host for this evening. Before we make a start, I'd just like to make a quick acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work. Okay, and I'd like to welcome our presenters for this evening, Dr. Tim Senior and Chris Carriage. So Tim is a GP at Tharawal Aboriginal Corporation in southwestern Sydney. He's an RACGP medical advisor for the National Faculty of Aboriginal and Torres Strait Islander Health, a senior lecturer in general practice and Indigenous health at UWS, and an RACGP medical educator. And Chris is the Indigenous Program Officer at School of Medicine at Western Sydney University. So thank you, Chris and Tim, for joining us tonight.
Good evening, everyone. Nice to be here.
Hello, everyone. How are you?
Great. In saying that, I will hand over to Chris and Tim now to take us through the learning outcomes for tonight.
So, good evening, everyone. It's lovely to join you here. Chris and I are joining you from Tharawal country in southwest Sydney, and we're both joining you from Picton. These are learning outcomes, which is essentially educational speak for this is what we want you to have learnt by the end of the session. So at the end of this session, at this hour together, we hope that you'll be able to explain how to systematically identify Aboriginal and Torres Strait Islander people in your practice, to discuss key health issues confronting Aboriginal and Torres Strait Islander people, to explain how to use the Medicare Health Assessment, item 715, and the related follow-up items, crucially, to address the health issues identified, and that we'll be able to list where to access appropriate clinical guidelines to deliver high-quality care. I'm just getting a few notes there. There's a few people who can't hear me. I hope that's not an issue with my microphone. So if we move on to the next slide. One of the things we're going to do tonight is take you through the college have a new set of guidance, which is hopefully making it simple for practices across the country and across the state to do Aboriginal and Torres Strait Islander health well. And we've essentially developed 5 steps, and we'll take you through these 5 steps. And the other important thing is that one of the steps will be introducing you to a resource that's about to come out very soon, then the 3rd edition of the National Guide to Torres Strait Islander health assessment in Aboriginal and Torres Strait Islander people. So if we look at the 5 steps first of all, and we'll take you through these, and we'll give you a commentary on each one of them. And feel free to post questions in the text box, in the question box as we go through. You've got to see this slide fairly frequently through the presentation, and the reason for this is that one of the crucial things about doing Aboriginal and Torres Strait Islander health well is the circumstances in which people live, and this is core general practice, really, understanding people in their context. And that all the problems that we might identify and the strengths that people have and the advice that we give is dependent on what we see in the context that people live in. And if you're an academic, you call this social and cultural determinants of health. I often think if you are able to use those terms, then you're not subject to poor social and cultural determinants of health. But the context that people live in terms of employment and income and their ability to get healthy food and their experience of racism in various parts of society that they come across, and their early childhood development and education and their housing and their interactions with Centrelink and Medicare and police and legal systems, and experience in the criminal justice system, and the choices that people make that affect their health, those are all determined by their context. As GPs, that won't be news to you, but it's really important in doing good Aboriginal and Torres Strait Islander health that we understand those and we take those into account as we're doing them. So we will be coming back to that slide just every so often, just to reinforce that this doing Aboriginal and Torres Strait Islander health well is not just about a set of medical conditions, though it doesn't include treating those medical conditions well. Chris, anything you'd add to that?
There's so many cultural contexts in that.
No, and that's right there. So while there's not much, those dot points don't include many cultural determinants. People's ability to live out their own culture is a crucial determinant of health. Those of you who are working in cross-cultural areas routinely will come across that a lot. And it can be a difficult thing to describe without seeing, without actually experiencing it. That'll become more apparent as we go through.
I think it's also a way that we can describe how people interact with their community, which we know is really great for emotional well-being and that mental health part of people's contacts and stuff like that. So I think it's a bit more than just, you know, cultural practices. It's that way that you interact with people's community. I don't think I hear me because my voice is about to lose it. Okay,
if we go to the next slide. So this is the first step in the 5 steps. So this is a summary of the 5 steps. We'll be sending around a link to where you can get the resources around these 5 steps as well as we go through. Essentially what we'll be going through is that the first step is to prepare your practice and register for the Indigenous Health Practice Incentive Payment. Even with the changes due to the PIP program that are suggested, it looks like the Indigenous Health Practice Incentive Payment will be remaining. The second is crucially to actually identify which of your patients are Aboriginal and Torres Strait Islander patients, and sometimes that's not obvious, but we'll be saying exactly why that's important as we go through. The third is to offer or to conduct health assessments on your Aboriginal and Torres Strait Islander people to identify the relevant health issues for those individuals and to work out tailored plans for those. We'll be talking about the crucial components of that and some of the resources that go to the best evidence on the best way of doing that. Step 4 is really important, is one of the ones that patients appreciate the most, and that's registering patients with chronic disease or patients at risk of a chronic disease for the Closing the Gap PBS co-payment. And the 5th step is actually tailoring care. There are some useful specific guidelines that could be used in Aboriginal and Torres Strait Islander health that are very important. So the first step is to prepare the practice, and really this is just recognising that in doing Aboriginal and Torres Strait Islander health well, it's not just the individual responsibility of the GPs, but actually doing it well depends on the whole practice. The Indigenous Health Practice Incentive Payment has been going for a few years now, and registering the practice for the Practice Incentive Payment and then registering individual patients generates some income to be able to provide chronic disease management for your Aboriginal and Torres Strait Islander patients well. Ensure that at least one of the GPs and it's one other staff member for the Department of Health have undertaken cultural awareness training and create a welcoming environment. Chris, have you anything that you'd suggest about the importance of cultural awareness training and the environment of general practices that make it welcoming for people?
Yeah, I just think that sometimes we tend to think that having those symbols of Aboriginality on the walls or whatever can be just that's enough, but I think that we need to take it that step further, and it is about that relationship, being Aboriginal or not. If you don't have that relationship, I think that you could lose patients in that way of like walking away. But it's just a little bit more, and it is about that relationship. And I know that Aboriginal would like connections with where they're actually seeing health and stuff like that. So
Yeah.
We come out the wrong way, wouldn't it?
Well, one of my favourite pieces of research was done in Mount Isa, where they asked Aboriginal people and non-Indigenous people what were the barriers to healthcare, to appropriate healthcare. Non-Indigenous people tended to talk about the policies and procedures in the practice, the posters on the wall, the pamphlets that were available, and that sort of thing, which will be very familiar to people. Aboriginal people said, actually, none of that matters. What we need is having a relationship with individual people in the practice. And as GPs, we should all understand that well and be able to provide that, given that the therapeutic relationship with our patients is core to what we do. And that's what Aboriginal patients are desperately crying out for. And if we do that well, you'll have patients who are really happy with the service you provide, even if the posters on your wall are no good at all. Sometimes that's what gets people peering in through the door. So a poster or an acknowledgement of country on the reception just says to Aboriginal and Torres Strait Islander patients, we've thought about this, we're aware of people's experience. And certainly asking Aboriginal and Torres Strait Islander patients their experience in other health services is a real eye-opener, because too often that's not been good. And so if we can be the one practice that provides a different good experience, then that's really useful. Chris, any advice you give about cultural awareness and training for that, or what's the crucial components of that?
Awareness is what it is. It creates that sort of like knowledge, which we all know what part of that is. I guess it's that stuff you take it a step further, and how do you apply your cultural awareness to your practice is what Jim was just talking about. I think that in creating those relationships and stuff and understanding where people come from because of what you've learned, I think that creates that trust, which we're all trying to do with all our people that we work with. So I'd be more interested in the fact that is, how do you apply that awareness to when you see an Aboriginal patient? And I think that's something that we all sort of like have to, I think, deal with. And I think, how do you do it?
It's often easier said than done, and I think one of the focuses for this hour will actually be about understanding the context and the thinking and the culture of the patient sat in front of you, and often they'll be able to guide you around that. Questions like, what are the sorts of things that you think will help with this? What are the sorts of ideas that you have about the cause of this? What would you like to do about this? And really inviting people to be involved and in control of their care. We'll come back to that issue frequently, because I think it's an important one. If we move on to the next slide. So this is just about the Indigenous Health Practice Incentive Payment. So when the practice signs on, you get a one-off payment of $1,000 for your practice. For each patient that you register, you get $250 per eligible patient each calendar year. And so you register people each year for the practice incentive payment. And then when you provide the majority of Medicare funded care for a patient, you get extra payments. So if you provide a majority of care for a registered patient in a calendar year, then you get $150 for each patient in the year. And when you provide a GP management plan and a review of a GP management plan, or 2 reviews, you get $100 for that patient. Now, the statistics that I'm aware of on the practice incentive payments is that there are quite a lot of patient registrations being done, and actually very few patient outcomes payments being made, which I think says that we're very good at registering people, but we're not as good at following people up as a result of that. And there's the same evidence on Aboriginal health assessments. But a question about how we register for this. So you register in the same way that you register the practice for other practice incentive payments. Because it's Medicare, is quite bureaucratic. For each patient, you have to register them on a particular form. The GP signs the form, the patient signs the form, and an eligible practice the authorised person at the practice signs the form and then faxes the individual form off to Medicare, and then that patient is registered. It's the same form for registering patients for the Closing the Gap PBS co-payment, though the criteria for that are slightly different. It gets a bit messy. There's good guidance, or reasonably good guidance, on the Department of Health and Medicare websites, and often PHNs are able to help you with that locally as well. But practice managers are often more across that than GPs are. If we move on to the next, and obviously only accredited practices are able to register for PIP. Step 2 is really important, and that's to identify your Aboriginal and Torres Strait Islander patients. We know that generally health services aren't that good at doing this. I think GPs are getting better at this. So there's 2 important steps. One is asking the right question, which is, do you identify as Aboriginal or Torres Strait Islander? And then you record that in the notes as Aboriginal, Torres Strait Islander, both, or neither. Now, a lot of people worry that they'll offend their patients by asking, sort of Indigenous or non-Indigenous patients, but actually if you can explain why you're doing it, then people are usually very happy about answering that question. Now, not only should you be able to do that, but it's important that your reception staff are able to do that, because those are the ones who are mostly going to be doing this. Chris, what's your feeling if you were at a practice and you're asked, are you Aboriginal or Torres Strait Islander? What's your instant response to that?
I usually go yes. And then because then I go, I know that what it's about. And so it's your average Aboriginal person who comes in and the first question they're going to go, why do you need to know that? And I think that's having that, like the reason why, and in people's own words, so that it comes across genuine, will actually put a lot of Aboriginal at ease as well. And I think that's the hardest part, is actually putting people at ease. Why are you asking this question? Does it mean, you know, whatever? And so I think that's, so asking it is hard when you first do it, but usually people have a story about, like, you know, like they have it in their own words. And I think that makes it much more easier for people to actually go, oh yeah. And that's also a part about developing that relationship too, and making it not sound like it's going to be an awkward sort of question or awkward situation once it's been answered. And
and it's worth remembering that for some patients that question would have been asked with a view to removing people's children, and so there are grandparents around and parents around where it's a really it's an awkward question to be asked. And so being able to reassure people that actually it's to provide the best clinical care. So some of the immunisations are different, some of the recommendations on preventive health care are different, and it allows us to tailor the care most appropriately for the patient and to understand some of the things that may have been in their background and experience and some of the issues that have come up with them. But it actually affects clinical care, which is why it's so important. One of the questions come through here is one of the common questions about this. What if the patient cheats? It's actually really unusual. I know of 1 or 2 GPs who've been audited for recruiting thousands of non-Indigenous patients to close the gap. The census numbers are known. So if you're a service where there's, say, I don't know, 100 people in your area who identify as Aboriginal and Torres Strait Islander, and then you register at 2,000, it's clearly wrong. In general, Aboriginal and Torres Strait Islander people have historically been kept out of services and kept away from services, and the funding has been less. So if we think about it as being, we can choose to be sensitive or specific. If we choose to be sensitive, we give the service to all of those who might be eligible, but we may give it to 1 or 2 who aren't eligible as well. Or we could choose to be specific, where we're really tightly targeting it, so we know that only those getting it are eligible, but we'll also miss many eligible people because we're being too restrictive. That's historically what we've done. We won't actually improve people's health if we're being too restrictive on applying it. There's actually very little evidence that that there's much rorting in this at all. If people have it explained, they're very happy. People are usually honest. There's not much evidence of rorting. The other important thing is you're not required as non-Indigenous GPs to police this. Yeah. If it would be a great way of ruining the doctor-patient relationship if the first thing you're doing is questioning someone's Aboriginality. So if someone tells you they're Aboriginal, you can believe them. Unless there's evidence of you rorting the system, and I suggest you don't do that, Medicare will accept in good faith what people are telling you. So the link on that page, by the way, goes to this document, which is the college position paper on identification of Aboriginal and Torres Strait Islander people in general practice. There's been quite a lot of good research about this, and that summarises some of that and gives recommendations for use in general practice. So do have a look through that, and encourage your practice teams to look through that as well. So I've gone back to this slide again. Again, just because to remind us that the history of being asked that question is not blank, and being aware of that means you're more likely to ask in a sensitive way, that people have, that there's a history of Aboriginal and Torres Strait Islander people being asked that question in order to be discriminated against. So I remember you saying something about the dog tag to me, Chris, about the reaction, that historically what that meant. Do you want to say something about that?
So that's when Aboriginal people used to have a piece of paper that said they were exempt from being Aboriginal. My grandmother had one, and she could go into shops to buy food for the kids, and she used it to her advantage to actually better the family. But the counterpart of that was also, they were also ostracised from their community, or they were and they were still not even accepted into the wider community anyway. So it was a fine, but most of it was used to actually let them use services, go into the supermarkets, all that sort of stuff. We had our own little mini apartheid. But yeah.
And these are vivid memories. People still draw on those memories when they're wondering why we're asking that sort of question. So again, social and cultural determinants are important. As we move on to the next slide, I'm just looking at some of the questions come through. There's some specific questions about particular scenarios in people's individual areas. If you have a look at the map of Aboriginal and Torres Strait Islander Australia, you'll see it's vastly different. There's hundreds of countries, different countries across Australia. And so for some of those specific questions, we actually won't be able to give you a specific answer here, because a lot of that is about local knowledge in your area as to whether there are particular services. And so contacting organisations locally, like perhaps a local Aboriginal medical service, the PHN might know, the local health district might know, and even local councils and local Aboriginal land councils will often be able to help with those question marks about services in your area. So the next step is about conducting an Aboriginal and Torres Strait Islander health assessment, which is the MBS item 715. You may well have heard about this already. The 715 is different to other health assessments that you might know of. It's not based around time. You get to bill that item number no matter how long it lasts. And you get to bill that item number for the 3 distinct ages. So there's a children's health check, there's an adult health check, and there's an older person's health check, but it's the same item number for all of those. It's designed to find particular problems and conditions that people are experiencing and give you an opportunity to discuss solutions to those problems. I think crucially, it's also an opportunity to build rapport with people. As we were saying, that relationship is so important. And so it's not just a medical questionnaire, but it's about building rapport and essentially being able to say to people, look, your experiences in other health services may not have been great. We're going to give you a fabulous experience, so that people leave a health assessment really wanting to come back and see you.
I also think that follow through is something really important. I think that we need to make sure that, you know, if there is an issue or something like that, is actually following through with that, and just making sure that the patient does come back with that. I think sometimes it doesn't happen so well.
And the statistics certainly back that up, that the number of health assessments being done is on the rise, but the number of follow-ups from health assessments is not that high. And if they're going to make any difference at all, the follow-up of health assessments is absolutely crucial. We'll talk about that in a little bit as well. It's got a comment coming through as well that sometimes patients deny being Aboriginal, and so again, that history is one of the important reasons that people may do that.
It's also their right.
Yeah, that's right. Go on to the next slide. It says a bit more about the components of a health assessment. So I think it's worth noting that health assessments are they're widely known about in Aboriginal and Torres Strait Islander communities. So people will often say, I'm here for a health check, I'm here for my health assessment. And so the awareness of them, I think, is quite high now, and people accept them as a way of getting health care. Medicare requires you to collect information, including taking a history and doing examinations and investigations as required, to make an overall assessment of the patient and recommending appropriate interventions and provide advice and information. Obviously, keep a record of the health assessment and offering them a written report. And if there's a carer, offering them a copy of the report. It can be done while you have to do while the GP has to summarize the information and have a discussion with the patient. A lot of the information gathering can be done by an Aboriginal health worker or a practice nurse. And you can see the Medicare requirements in general. So in general, leave the clinical decision making up to you, but it's about taking a thorough history and examination and making recommendations based on that. Anything you'd suggest?
I just had a thought that's been chatting.
Oh, okay.
It was just about that sort of. I think too around the health assessment is to get Aboriginal people and Torres Strait Islanders to think differently about their health. I think it's a bit more than just, you know, like sometimes we come in with an attitude of, yeah, it's going to happen anyway. So, but I think that we need to start thinking about with regular checks, with regular health, we can actually improve your diabetes, we can actually improve your weight, we can all those sort of things that most other people have that sort of like view when they come into a clinic. And I think that's the toughest part is actually to change our view on our own health status.
I think that's a really good point. I've met quite a few people where their brothers or sisters have died, say, in their mid to late 50s, and they reach that age and they have a sense of inevitability that that's going to happen to them. One of the important things we can do is say, this isn't inevitable. There's a lot that we can actually prevent if we do well. There's a question coming in asking about whether family members have mental illnesses or not is culturally sensitive. There's a widely understood concept in Aboriginal and Torres Strait Islander communities of social and emotional well-being. It's actually a broader concept than our concept of mental health, that being healthy and well is more than just an absence of diagnoses such as depression or schizophrenia, but is about your well-being in the context of your community and family. And asked in that way, I've never come across a patient who says, "Oh, I don't feel comfortable you asking me about that." Would you feel people would be comfortable being asked about that?
I think the hardest thing about this is defining mental health for an Aboriginal community or family, because I think that if you said that someone was sad in my family, I could tell you yes. If you say they had depression, I wouldn't know, in a sense. So there's this sort of like levels of what mental illness is, and so that's probably the hardest part about that. And I think if you say, I don't know how you would even answer. Saying mental health is one thing, but saying emotional well-being or, you know, your I think it's harder.
Most patients have family members or friends who've been affected by mental health issues, and so they understand that, and they see the effect on people, and they don't want it to happen to them. It's difficult for everyone to talk about their own mental health.
Well, you say mental health, it puts a stigma straight
Yes.
away, and that's the thing I think they avoid the most. When you say if you're sad or you're not coping or anything like that, then you can go, okay, what is it? I'm frightened of going outside. Then we know that's an anxiety sort of issue as well. And I think it takes another family member to bring someone to a service that says there's something wrong here, we need to actually help.
That's a really good point. That actually not talking about it in terms of a particular mental health diagnosis, but talking about it in terms of what you do and how you feel in the community and what it stops you from doing, like feeling frightened about going out is much more important than saying, do you have an anxiety disorder? The question, what works to engage people to come in for their 715 health checks? Different communities have done all sorts of different things. AMS Western Sydney have published about their health days and the services that do sort of big days of offering checks, and the services that we offer fruit and veggie boxes to some of our patients, a subsidised fruit and vegetable program. Other services will offer t-shirts to people to come. Some offer there's various things like that. In general, it comes from the community themselves.
Yeah, and it's changing that narrative of what health is, I think, for Aboriginal people, and changing their view of their health. And I think that's the hardest.
Yeah. If we go on to the next slide, which I think will be familiar to you, because it's important again to realise that a lot of the health issues have this social and cultural background. Cultural being a strength, connection to culture is a protective strength and is important to determine, and so much of those issues are important in experience of people's health.
It's interaction with family, community. It's a whole range of issues that's part of that cultural, I think, makeup of what makes the community, and having those places to go or somewhere where they can interact with their family, community on a whole.
Someone's asking, do you do a mental health assessment in the next appointment? Do it when you feel is appropriate, depending on the relationship. There's no hard and fast rule about that. Someone's asking, do you do an Aboriginal health assessment instead of a GP management plan? So people with a chronic disease are still eligible for a GP management plan. So you can do both if people have a chronic disease. And I would suggest that's actually a useful way of utilising Medicare for your care. How often do you do a 715 assessment? They're designed to be annual, but actually you can bill another one after 9 months. But it's designed to be an annual health assessment. Yeah, so if we move on to the next slide. This is about follow-up, and as I was saying, follow-up is really crucial. It hasn't happened, the statistics show it's not been happening as much, but you can actually bill the service, your practice nurses can bill 10987, so you can remember that 10987, to provide follow-up activities arising from the health assessment. So talking to patients about taking medication and monitoring for that, checks on clinical progress and accessing other services, education, monitoring, council activities, lifestyle advice, doing further medical history and prevention advice and associated follow-up. So that's that can be a really useful option for use in your practice. And next slide. Just before we go on to step 4, the other thing I just want to say about follow-up is that it's a whole of practice activity. So don't just depend on your memory or the patient's memory for the follow-up activities. Use your practice system. So use your recall system, discuss with the practice manager and receptionists about how you can get people back. Use your appointments book proactively so that if you see someone who's had a health assessment coming back in, then you're able to do some of the follow-up at that point as well. There's sort of have an active follow-up system. So step 4 is registering patients who have or are at risk of a chronic disease for the Closing the Gap PBS co-payment. One of the biggest barriers to people actually taking the medication was being able to afford the medication. And this has been one of the most successful measures in the whole Closing the Gap program, was actually reducing the cost of medication for Aboriginal and Torres Strait Islander people. So registering for the CTG means that all PBS medications, not just the ones for the chronic disease or preventing chronic disease, everything on the PBS is reduced in cost. So for people who aren't on a healthcare card or pension, that reduces the cost from about $36 to $6 to the pension cost. And for those who are on a pension or healthcare card, it reduces the cost of each prescription from about $6 to being free. That's made a huge difference to people actually being able to make the decision to take their medication and be able to feed the family rather than choose one or the other. Anything you'd say about that, Chris?
No, I just I think it has made a big difference in people's lives who do live on, who are on the edge too of that sort of like unemployment and stuff like that. And I think it makes a difference to people's lives. I really do.
It's when you look at the statistics about people's income, you see why this is such a big thing, because the troubles that people have with income makes it really difficult to be able to just afford basics that we would take for granted. If we move on to the next slide. So again, just remembering, this is to remind us that income is really important. There's a question coming through about any strong criteria to register as Aboriginal and Torres Strait Islander. Some people say their parents are Aboriginal, but they're not sure. In terms of general practice, the only criteria is if someone says they're Aboriginal or Torres Strait Islander, then they're Aboriginal or Torres Strait Islander. And you don't need to get into an argument about that. It only provokes grief. So if someone chooses to identify, then for our purposes as a GP, that's good enough. So another question. Oh yeah, this is important. Can you get 5 sessions with allied health practitioner per year on a 715 and 5 sessions with a GP management plan? Yes, you can. So you can use, so for an Aboriginal patient with a chronic disease, you can use the Medicare health assessment 715 and the GP management plan and team care arrangement 721, 723 to get 10 allied health appointments each year. You can imagine for someone with diabetes who might need to see a dietitian, podiatrist, diabetes educator, that those 10 sessions are really crucial. And so we certainly do that at Tharawal, and you're certainly able to do that. Step number 5 is about using appropriate clinical guidelines and programs from RSCGP, Medicare, primary health networks, and local health districts to enhance access and quality of care for people. So one of the, I'm with the college, I work in the national, in RSCGP, Aboriginal and Torres Strait Islander Health, and so one of the big projects we've been involved in for a long time and is just coming out in 3rd edition is the National Guide to Preventive Health Assessment for Aboriginal and Torres Strait Islander people, which is a partnership between NACCHO, which is the National Aboriginal Community Controlled Health Organisation, and the RSCGP. And so if you watch out, within the next month, I think those guidelines are going to be launched. And those are essentially like the Red Book for Aboriginal and Torres Strait Islander people. If you move on to the next slide, I think we've got more on that. So this is, that's the cover of the previous edition. The new edition is coming. And essentially, it looks at the evidence for, or makes recommendations based on the evidence for different preventive interventions. And some of those interventions are slightly different to what you may be familiar with in the Red Book. Predominantly, some of the immunisations are different. Some of the interventions start at a younger age than they do for non-Indigenous populations. So, for example, testing cholesterol, checking renal function, testing for diabetes. And there's also sections in the National Guide for things like there's a new chapter on violence and abuse and picking that up. So do watch out. So the second edition is still available on the college website, but within the next month, the brand new third edition will be launched. So do watch out for that. We'll move on to the next slide. Oh, there, look, that's a sneak preview of the cover of the third edition, so you know what it looks like on the website. And if you're get a hold of a hard copy, which will be sent around as well. Just some of the other questions coming through. The difference in Medicare rebate between a referral from a 715 and 721, 723. I can't remember off the top of my head. They're very similar. The list of allied health practitioners is just the same. I have a feeling the Medicare rebate may be the same. The form is ever so slightly different. It has a different tick box at the list. It says 715 to tick rather than a 721, 723. It's pretty similar. And the other one is, do you have to do a 715 every year to get the 5 extra allied health sessions? Yes, you do. So once you've used the 5 in a calendar year, that's your lot, and you have to repeat the 715 the year later to get the next 5. Are there any schemes for Aboriginal patients to access dental care under the Medicare rebate? No, this is a real gap. There is just a new this isn't just for Aboriginal patients, but there's $1,000 over 2 years Medicare rebate for children of families on the Family Tax Benefit Part A. $1,000 isn't much, but that's what Medicare are offering for some child dental care. Dental services are really difficult to get hold of. Public dental waiting lists are long. Many Aboriginal medical services do run a dental service as well. Were you going to say?
It's okay, Mr. Chief.
Yeah, okay. But you're right, dental care is crucial. Without sort of good teeth have an impact on everything from being able to eat the fresh fruit and vegetables that we recommend to actually being confident enough to smile in your job interview to get a job. So it's actually really crucial. This next slide is about the barriers to follow-up. Just aware of the time, have a think in your own practice about the reasons that people may not be able to come back for follow-up after health assessments. I think there's no right or wrong answers, particularly in this, because each one of our practices is different and working in our own local context. But it's important that we understand these in our area, because coming back to solve problems using the strengths that we've found in health assessments is crucial to actually making a difference. So as suggested there, remoteness and isolation, as in the photograph there, can certainly be one issue. And that would be true in many parts of New South Wales and certainly in other parts of Australia, but by no means all. And it is worth remembering that the majority of Aboriginal and Torres Strait Islander people do live in urban areas, so remoteness isn't always a problem. Having said that, there are still barriers to accessing care, even 5 minutes away. Chris and I work, well, Chris is on the board and I work in a service 5 minutes from the local hospital, but there's still barriers to going to that hospital, even though it's within reach. If we move on to the next slide. There's some good questions there. So yeah, someone's asking why I've said that. So there's a few different reasons. One is that when people attend health services, including our own, they are often treated rudely at the reception desk. Income and affordability of services can be an issue for many people. The other calls on their time. So often people who are most need of having health assessment follow-up are also having to deal with Centrelink appointments, housing appointments, schooling, other medical appointments, work in their day-to-day. So there's lots of other calls on people's time as to why they may not be able to make it. I've found it useful, and I think this comes from one of the research articles about the different levels of care that can prevent people from coming into to services. Someone's putting it, isn't hospital free for everyone? Yes, but there's no, it's a 2-year waiting list to get and see a public ophthalmologist where we are, and then another 2 years to actually get your cataracts operated on. There's no public orthopedic outpatients clinic. It's hard, long waiting list for hematology. There's no public ENT appointments. So the public system, while it should be free, often relies on the private system to get people in, and the emergency department becomes the default position where people are waiting a long time. So if we move on to the next slide. So this is talking about the patient level. Transport's a big issue, and again, sort of creating the desire in the community for people to follow up their health assessments, and the system in the practices to do that. Chris, would you have any advice for people around sort of engaging community to enable people to come in back for health assessments? Sorry, I've dumped you in it there.
I know, no, it's okay. I just kind of thinking about it. It's such a there's a whole range of things, and I think it's that thing like we said before about relationships and building that trust. And I guess it's that thing, those little personal touches. I think with, like, if you look at AMSs and how they get people back, it is that shared knowledge. It is that someone asking how your aunt's going, or there's extra questions that builds relationships. And if you're in a practice where you have a relationship with your patients, I think remembering the smallest things sometimes can actually help. But yeah, and I guess I mean, you've got to think that sometimes people come in and they have to navigate the surroundings, the staff, the other patients within that service, and then understand the talk that doctors talk about their own health literacy and understanding their own health. I think it's not just easy as a team or a patient.
And I do think the relationship that you have with people, if that's there, people are much more likely to come back. We do think about the practice systems that allow that to help. Next slide. Someone's commenting that in rural areas, rural communities, often a transport bus with local drivers. That's often very helpful. That's absolutely right. We work with drivers who take people around, and recently have several occasions where the drivers have made a significant intervention in knowing the patient well and realizing that they're not well, and have brought them in to see the doctors when the patient wasn't considering it. So the drivers are really valuable, both in their transport role and elsewhere. Again, that's just stressing the importance of cultural awareness, and that really that can boil down to an awareness of the context that people are living in and what's important to them. So we tend to think that diabetes is important, and ischemic heart disease, and HbA1cs, and blood pressure. Our patients feel that their grandchildren and connection to community and community events and looking after family is important. There's common ground in there, but we need to understand that from the patient's perspective. We'll move on to the next slide. Someone's making again, a really important comment about the involvement of the Aboriginal health worker. Many of you may not have Aboriginal health worker in your practice, but PHNs often include Aboriginal health workers, and they can be involved. They'll only be too happy to be involved in your care. Hospitals often have excellent Aboriginal liaison officers who can really make the difference in transitioning care between hospital and primary care. So do look out for those people and engage their help. This is a health service level about way of follow-up. So that using the clinical information system, using all the staff, and again ensuring that all the staff in the service are able to develop a relationship with your patients, and again, cost is an issue there about communicating cost implications of referral for follow-up, and finding ways around that often. So there are often schemes locally, the Integrated Team Care Programme, which is usually contracted out by the PHN to a service in your area. Look out for them because they are often able to help some of the cost barriers. Specialist care can be difficult. There are programs run by the New South Wales Rural Doctors Network for getting specialist outreach programs into different communities, and I know the Royal Australian College of Physicians is also doing quite a lot of work to try and get specialist outreach into communities across Australia, including New South Wales. So this is community level, and Chris, you're often, I've heard you say before, community know what it is that they need, and they don't need to be told again that they're sick.
Yes, definitely.
Yeah. So what would you say about how communities convey what they know and what works for getting communities engaged in doing health assessments?
Like as in health workers, or as in
so what practices can do to make this work better for actually doing follow-up of health assessments?
So I really like your suggestion about getting the PHN's team involved with her care of her patient and stuff like that. I think sometimes it could be quite difficult for that connection, and sometimes the Aboriginal health worker has that connection with the patient themselves. I think that there's a whole lot more than just a sort of like a community sort of, that like knowledge and stuff like that. But I think it's a thing around if you show that you do that thing about caring and building that trust, and just saying we're going to have someone else part of your care. I think that as Aboriginal people, we go, oh, okay, then, so, and having the Aboriginal liaison officer come in there, or the Close the Gap team from the PHNs, I think it makes a better whole of care than just having it all placed upon the one person, the doctor and stuff like that. And I know that you don't just not just you, you've got a whole team that sits behind you to help you with the patients and stuff like that.
And certainly I'm lucky enough to be able to work with Aboriginal health workers who regularly just are able to give me a heads up on what's happening with someone, or what's happening in their family, or some issues that they didn't feel comfortable raising with me that they're aware of or has been mentioned, and just opens my eyes to something that I wouldn't have guessed, that allows me to provide really much better care. So I think that can be a really important thing. And they can say things to patients that I could never get away with saying. So they'll grab someone by the ear and take them in, well, not literally, but drag them into my room saying, get yourself in to see the doctor. And they can say it in a forceful way that I would just alienate someone if I did that. But because the health workers in the community and trusted by people and known by them, they can get away with being a little bit more brutal than I can.
I know, ambulance driver nearly died when I told somebody he didn't get into the car. I was going to into the ambulance. I was going to kill him myself when he jumped into the ambulance.
So I just wouldn't get away with saying that.
I mean, one of the things too, we'll talk about like the Close the Gap teams with the PHNs and that. I mean, that's what they're for too, and I think that they have a team of things to do. But I think as GPs, I think actually trying to utilise them better and formulate the way that they can actually help you with that whole care service is a really good place to start with.
Yeah.
And they can also help you break down those barriers within your service and staff as well. So
yeah, absolutely. So if we move on, and I think the take-home message from that is really that that health assessments can be a useful tool, but only if the follow-up is done well, and that sort of thing requires the use of practice systems rather than just memory and hoping that it'll happen. And I think, and again, a reminder that the social and cultural determinants of health give people a large call on their time that may mean what's a priority for us takes a less of a priority if people are sort of wanting to keep food on the table and a roof over their head. So it's very important just for us to understand the context that people are in, which is very often very different to our own. Someone's just asking how many times a 10987 can be charged. It's a good question. I can't remember off the top of my head. I think it's 5. We put in a submission to the MBS review arguing that should be many more or uncapped, because capping it is can be a problem because it's limited, but I think it's 5. There's a common question here that I think is important about, are there any really taboo things that I should be aware of specifically when seeing Aboriginal patients that may not be obvious to someone? Not really. Chris, anything taboo?
no, I don't think there is. I think I mean, there is like women's business and men's business, and I guess if you're a man working with a lady, an elder, or especially an elder in the community, and I think you need to ask those permissions. You know, do you mind if I touch you? Which you would probably do normally anyway. Asking if they would like a female doctor or something like that, but usually they will seek out a doctor that they feel comfortable with too. So I mean, that's probably the biggest issue that you would probably come across. Male doctors, male patients who, unless they're really elderly, will kind of feel comfortable with everyone. I don't think they've got such a thing, but there is that sort of like, and just being mindful of that sort of like shyness, I guess, is something. Yeah.
So I've worked at Thurrock about 12 years now, and I don't do that many pap tests, and I don't do much antenatal care. It's not because I don't want to, it's just that it's women's business. But I don't do none. So it's not an absolute hard and fast rule. I think I don't do. And I think the other thing is just some of the terminology. Be careful. It's probably not good to call people ATSI. The acronym doesn't work. Don't use some sort of derogatory terms, which is obvious to say. You wouldn't do that about anyone anyway. Yeah. But the correct terminology is Aboriginal. As a collective noun, Aboriginal and Torres Strait Islander people, Aboriginal and Torres Strait Islander Australians.
So are you invited then to call people auntie and uncle if they invite you to?
Again, I think the point about asking permission for that is important.
Yeah.
And in general, watch for the body language. If you're making people uncomfortable, they'll show it in the way that they're interacting with you.
Yeah.
People often ask, as being asked about whether eye contact is taboo. Don't worry about it. So in Central Australia, when I worked there, people would avoid eye contact. It doesn't happen at Tharrawal and Southwest Sydney very often at all. If you look at the Aboriginal map of Australia, then it's many countries, and they all are slightly different. And so it's going to depend on local sensitivities, and there's not a single rule that would apply all across Australia. If we move on to the next slide, we're just coming to an end now. This is the summary of the learning outcomes. So we hope, I'm just having a quick look to ask. Oh, we've got a question to ask, which I think is worth answering for clarity. Chris, we're being asked, is it okay to ask, are you Aboriginal? So I'm not Aboriginal, Chris.
I am Aboriginal.
And Chris is Aboriginal. Yeah. I think one of the important things is that feel free to call out anyone offering Aboriginal health teaching who's not doing it with an Aboriginal person, because that shouldn't really happen. Aboriginal health for too long has been non-Indigenous people talking amongst themselves about how to do it well, and one of the most crucial things that I think will have come through tonight is to involve Aboriginal people in their own care. Develop that rapport and do that, and that's going to be the most important thing. I hope we've covered all those learning outcomes for you. You can let us know in the evaluation afterwards. I think Sammy's going to send around some links and possibly some resources and handouts. Those 5 steps that we went through and the National Guide are both available on the college website. So, and there's 3 resources linked to the 5 steps. And so feel free to have a look at those.
Sorry, Tim. I just want to also mention as well that I've just posted a link in there. We've actually, on the RACGP New South Wales and ACT faculty page, we've got a video there on identifying Aboriginal and Torres Strait Islander people in your practices. It's only a 2-minute video, but it's a great resource. So please do jump on there and have a look at that. And that brings us to the end of this evening. A big thank you to Tim and Chris for presenting tonight, and thank you to everybody that joined as well. We hope you found it really beneficial to your education as a GP.
Thank you very much, everyone. Thank you, Chris.
Yeah, thank you. Thank you.
And have a good evening. Thank you very much.
Great.
Bye.
Just a reminder to everybody as well that this is a CPD activity. If you can please complete the evaluation so we can upload your points. Thanks.
Thank you, Sammy.
Thanks, Sam.
Good night, everybody.